everyone. My name is Addison, and along with my classmates Katie, Lucas, and Hannah, we are the University of South Dakota nurse anesthesia students, and we thank you for taking the time to participate in our doctoral project presentation. So, throughout this presentation, we will be discussing the anesthetic management of patients who use cannabis and their possible implications in the perioperative period. So, as cannabis use continues to rise, this is something we're encountering more frequently in practice, and it can definitely add some complexity to our anesthetic management. So, our goal is to break down what we currently know and, more importantly, how you guys can apply that information in your day to day practice to provide an overall safe and effective anesthetic. So, to start, we want to highlight what you're hoping to take away from this. We'll start by going over how cannabis affects the body in ways that matter for anesthesia, and then we'll move into some of the perioperative risks that we might see. From there, we'll talk about practical anesthetic considerations and things you might notice intraoperatively that could kind of clue you into cannabis use. Overall, the goal is to help you feel more confident recognizing these patients and incorporating that into your clinical decision making. So, along with that, we really aim to improve overall knowledge, build your confidence, and help you feel more prepared managing these patients so that the care is more consistent and safe across the board. A little background, as you all know, cannabis use has really increased across the US, especially with more states legalizing both the recreational and medical use. And because of that, we're seeing these patients a lot more in our anesthetic practice. And it really does matter to us as anesthesia providers because cannabis can affect hemodynamics, they can change the anesthetic requirements, and they can lead to some pretty unpredictable responses under anesthesia. So the challenge is that even though we're seeing this more often, there really aren't any standardized guidelines for how to manage these patients in the perioperative setting. So a lot of it ends up being provider dependent, which can create variability and potential safety concerns. So that's really where this project comes in. We want to focus on the education to help bridge that gap and make managing these patients feel more consistent and a little more predictable in practice. So a little brief overview of where we got our evidence for our project and what we're about to present to you guys. We used a mix of different types of evidence like cohort studies, reviews, expert opinions, and a randomized control trial to get more of a well-rounded view of cannabis use in the perioperative setting. We did this because it's still an evolving area and there isn't a ton of high yield data yet. So the studies ranged from levels 1 to 5, with most being good to high quality, and these were published between 2002 and 2024. Limitation to keep in mind is that there's still a lack of large randomized control trials, so some recommendations are based on lower level evidence.
So at this point in the presentation, we're going to start talking a little bit about the physiologic and pharmacologic effects of cannabis that these patients experience under general anesthesia. So as we've said, cannabis use has become increasingly common as legalization and medical access continue to expand across the United States. The active compounds in cannabis interact with the body's endocannabinoid system, producing a variety of physiologic and pharmacologic effects that can influence cardiovascular, respiratory, neurologic, and immune functions. These effects may alter anesthetic requirements, pain perception, airway reactivity, and post-op recovery. Because these patients may use cannabis recreationally or medically, anesthesia providers must understand how cannabis impacts perioperative care in order to recognize potential risks, anticipate drug interactions, and provide safe and effective anesthesia management. So before we can discuss the physiologic and pharmacologic effects of cannabis use, we must first talk about the endocannabinoid system and where THC and cannabis products interact within the body. So this system was identified in 1960 and is still relatively new within the whole landscape of systems within the body. So THC and cannabinoid products exert their primary effects on the endocannabinoid system, particularly targeting receptors CB1 and CB2. The CB1 receptors are located throughout the brain as well as in peripheral tissues such as the liver, pancreas, GI tract, and muscles. In contrast, the CB2 receptors are primarily found on peripheral immune cells and play an important role in immune system regulation. So, cannabis use primarily targets the CB1 receptors, which is why it can have widespread effects on both brain function and various body systems. Through its action on both the CB1 and CB2 receptors, however, homeostasis becomes disrupted and a new baseline is created, resulting in perioperative effects that are not seen in the standard patient, meaning that these patients undergo varying degrees of reactions to anesthesia based on different stimulations that are not seen within the patients. So now we're moving on to the respiratory tract and the differences that these patients face compared to a non-cannabis using patient. So cannabis use is associated with several respiratory concerns that are highly relevant to anesthesia and perioperative management. Regular inhalation of cannabis, particularly through smoking or vaping, can cause airway inflammation, increased mucus production, and impaired mucociliary clearance, leading to symptoms like chronic bronchitis. Studies have shown that habitual cannabis users have a higher rate of respiratory disease, including chronic obstructive pulmonary disease, compared to non users. Airway hyperreactivity and edema can increase the risk of perioperative complications such as laryngospasm and bronchospasm, as illustrated in case reports like White, 2002. Literature reviews also note that cannabis smoke contains many of the same irritants and carcinogens as tobacco smoke, potentially leading to long-term respiratory compromise. Acute cannabis use can increase airway resistance and cause coughing or bronchial irritation, complicating airway management during induction and emergence from anesthesia. Furthermore, alterations in respiratory drive due to the central nervous system effects of THC may interact with anesthetic agents, heightening the risk of hypoventilation or postoperative respiratory depression. The evidence suggests that cannabis users are at an increased risk for perioperative respiratory complications, emphasizing the need for detailed preoperative assessment, anticipation of airway reactivity, and cautious titration of anesthetic and analgesic medications to maintain respiratory stability. So, cardiovascular concerns for patients who use cannabis are well documented across several studies and reviews. Cannabis use is associated with multiple adverse cardiovascular effects, including arrhythmias, myocardial infarction, and decreased cardiac function. Research indicates that cannabinoids, particularly THC, act on the cannabinoid receptor 1 located within the cardiac tissue. Activation of this receptor can alter heart rate, contractility, and rhythm, and it has been linked to an increased risk of arrhythmias and, in severe cases, sudden cardiac death. Systematic reviews have identified a correlation between chronic cannabis use and cardiovascular complications, including cardiomyopathy, congestive heart failure, and recurrent cardiogenic shock. Case reports and clinical reviews further support these findings by demonstrating episodes of cardiac dysfunction associated with elevated THC levels. Large cohort studies have reported higher incidence of postoperative myocardial infarction, deep vein thrombosis, and overall medical complications among cannabis using surgical patients. It is well documented that cannabis use may contribute to hemodynamic instability during anesthesia by affecting heart and blood pressure responses, as we've all seen. Collectively, these findings underscore the importance of thorough preoperative screening and vigilance in hemodynamic monitoring, as cannabis use poses significant implications for cardiovascular stability and anesthetic management during the perioperative period.
The effects of cannabis on the central nervous system were mentioned in a few of our articles, so I'll briefly touch on them here. In the preoperative setting, patients reported greater functional impairment, higher pain scores, and more anxiety and depression. Postoperatively, these patients reported higher pain scores at 3 and 6 months post-op and had increased rates of opioid use before and after surgery. There is some variation in studies on how cannabis use affects postoperative nausea and vomiting. Acute use tends to provide an antiemetic effect, which correlates to decreased reports of postoperative nausea and vomiting. Chronic use doesn't elicit the same effect, which I'll touch on more in the next slide. So many patients have used cannabis medicinally to treat nausea and vomiting, specifically in cases of chemotherapy and cancer treatment. The effects of cannabis on the GI system during the perioperative period are varied based on acute and chronic use. Patients who are considered acute users experience antiemetic effects and reduced GI motility, which may have implications when considering whether a patient is full stomach or not. Interestingly, patients who chronically use cannabis tend to report increased incidences of severe postoperative nausea, vomiting, and severe abdominal pain. This is called cannabinoid hyperemesis syndrome. Standard antiemetics like Zofran and Reglan aren't effective in treating this syndrome, and it's characterized by its cyclical effect. Cannabis use also has some effects on the endocrine system. Cannabis may cause the body to decrease the secretion of growth hormones, androgens, and prolactin, which can lead to decreased gonadal function in both men and women with chronic use. It's also important to understand how cannabis affects energy storage in the body. Acute cannabis use causes increased energy intake and storage through adipogenesis, which is the formation of fat cells. It also causes increased glucose uptake. Research shows that chronic cannabis use decreases insulin secretion and causes glucose intolerance. This may make the patient population more susceptible to hyperglycemia, which has been shown to have clear negative impacts during the operative period.
When we look at anesthetic requirements in patients who use cannabis, the evidence shows some important but not always consistent trends. Several studies demonstrated that cannabis users often require higher doses of propofol, fentanyl, ketamine, and midazolam. For example, a randomized trial found that cannabis users required significantly higher doses of propofol to reach the same level of sedation compared to non-users. In fact, across multiple retrospective and prospective studies, this pattern of increased anesthetic demand has been consistently observed. The most likely explanation for this is pharmacodynamic tolerance. Chronic exposure to cannabinoids leads to ongoing stimulation of cannabinoid receptors, which can blunt the effects of anesthetic and analgesic medications. However, it's important to recognize that the data is not completely uniform. Out of 25 studies reviewed, a small number found no statistically significant difference in anesthetic requirements between cannabis users and non-users. For instance, one study evaluating patients undergoing endoscopy did not find a difference in dosing. This variability suggests that anesthetic requirements may depend on several factors, like the type of the procedure, the anesthetic technique being used, and the patient's pattern of cannabis use. In addition to dosing requirements, cannabis also affects how anesthetic drugs are processed in the body. Cannabinoids interact with the cytochrome P450 enzyme system, which can either increase or decrease the metabolism of anesthetic medications. This means drug effects may be prolonged or in some cases reduced. There are also important physiologic considerations. Chronic cannabis use has been associated with altered sympathetic tone and cardiovascular instability, which can present as fluctuations in heart rate and blood pressure during anesthesia. So the key takeaway for anesthesia providers is to anticipate an increased induction and maintenance dosing requirement, potential variability in drug response, hemodynamic fluctuations, and possible drug interactions. Next, we'll discuss perioperative considerations. Some of this information will be a repeat of what was presented earlier, but it'll be nice to hear it again just to solidify the information. Starting with the preoperative phase, a thorough history is critical. We want to assess the frequency of use, route of administration, whether it's smoked, vaped, ingested, and the timing of last use. Identifying patients with cannabis use disorder is also important, as these patients may have more pronounced physiologic effects and perioperative risks. From a cardiovascular standpoint, cannabis can cause tachycardia, hypertension, and in some cases increase the risk for arrhythmias or myocardial ischemia. This is especially concerning in patients with underlying cardiac disease. Pulmonary assessment is also key, particularly in patients who smoke cannabis. Chronic use has been associated with airway inflammation, increased sputum production, and bronchial irritation, similar to tobacco use. We also need to consider acute intoxication. If a patient is intoxicated on the day of surgery, elective procedures should be delayed due to concerns with impaired consent. Lastly, cannabis interacts with CYP450 enzymes, which can alter the metabolism of anesthetics, opioids, and benzodiazepines. So overall, patient education and disclosure are essential for safe anesthetic planning. Moving into the intraoperative phase, one of the most consistent findings in the literature is increased anesthetic requirements. Chronic cannabis users often require higher doses of propofol for induction, as well as higher concentrations of volatile anesthetics. This is likely due to pharmacologic tolerance. Hemodynamic instability is another concern. Patients may experience tachycardia, hypertension, or even hypotension, so close monitoring is essential throughout the case. Airway management can also be more challenging, particularly in patients who smoke cannabis. These patients may have increased airway reactivity and a higher risk of bronchospasm. In terms of analgesia, cannabis users may require higher doses of opioids intraoperatively, and will later learn postoperatively. There is some evidence suggesting cross-tolerance, which can complicate pain management. Because of all these factors, anesthetic dosing should be individualized and carefully titrated.
So at this point in the presentation, we would just like to open up for discussion based on any clinical experiences that you have noticed when dealing with these patients or any challenges that you have noticed. As we mentioned, this is still a relatively understudied area of anesthesia care, and there's obviously variance amongst patients. So any feedback you could give us about what you have experienced would be great. There's a comment section at the bottom of the post test. Otherwise, we all thank you very much for participating in our study, and look forward to reading your responses.
In the postoperative phase, cannabis users often present unique challenges. These patients frequently report higher pain scores and require more opioids postoperatively. This may be due to altered pain pathways and changes in the endocannabinoid system. Because of this, multimodal pain management strategies are recommended. This includes using non-opioid medications, regional anesthesia when appropriate, and adjuncts like ketamine or dexmedetomidine. We also need to watch for cannabis withdrawal, especially in heavy users. Symptoms can include irritability, anxiety, insomnia, and nausea, and may begin within 24 to 72 hours after cessation. Interestingly, although cannabis is sometimes used for its antiemetic effects, chronic users may actually have an increased risk of postoperative nausea and vomiting. There is also the potential for cannabinoid hyperemesis syndrome, which we talked about earlier. Respiratory complications are another concern, particularly in patients with a history of smoking. These patients may be at higher risk for hypoxia or airway issues postoperatively. Finally, cannabis use has been associated with longer hospital stays, increased complications, and higher healthcare costs. Here's a table that summarizes all of the perioperative considerations that we just went over.
So this is the summary of our project. Cannabis use is becoming increasingly prevalent among surgical patients in the U.S. Cannabis use leads to physiologic changes in various organ systems, which changes how our anesthetics may work in the body. The organ systems affected that are relevant to our practice are the respiratory, cardiovascular, central nervous, gastrointestinal, and endocrine systems. To briefly go over some highlights again, the respiratory system is at risk of inflammation and bronchospasm. The cardiovascular system is at risk of myocardial infarction and arrhythmias. The central nervous system effects cause altered pain perception and increased opioid consumption. The gastrointestinal system is at risk of cannabinoid hyperemesis syndrome, and the endocrine system faces hormonal and metabolic imbalances. There's also an increased anesthetic requirement with many of our commonly used medications such as propofol, ketamine, and fentanyl. The physiologic changes that we discussed may be highly variable from patient to patient and how much cannabis the patient's using. To help plan future anesthetics and properly mitigate patient risk, it's important to do a thorough individualized preoperative assessment. And then finally, the study of cannabis and its effects on anesthesia is evolving and being continually researched. This future research will be imperative for future standardized perioperative guidelines.